So we're going to start out with our first case. So this is a 35-year-old gentleman who had a hyperflexion injury to his knee. He has had medial-sided joint pain, and he does not have any swelling associated with it. He has no prior surgeries, and this has been going on for approximately 1 month. These are his x-rays and MRI findings here. So we'll just start, first of all, asking, do you guys see anything significant, or are you impressed with these images, or what are your initial thoughts if this patient's in your office? So significant medial pain, tenderness to palpation in the medial joint line, tenderness to the medial femoral condyle, no fusion, ligamentously stable. 35.
So initially, I'm thinking 1 month history of symptoms, this guy's never going to get into my office because he's going to be waiting an awful lot longer. I think that's where the benefits of a long wait time actually is, because I think his knee's just going to get better without me actually seeing him. But in any case, there's obviously there's a little bit of change there in his articular cartilage and his sagittal MR, but at this stage, I'm not that concerned, and I certainly wouldn't be thinking about anything operative at this point in time. So for me, I'll be really pushing down the route of understanding what his symptoms are and then hoping for a non-operative solution. But I want to see some more slices.
Yep, so that totally makes sense. Any other thoughts? What would you actually do with him? What would you recommend for him? Give him more time? Any intervention at all?
Well, I mean, with the mechanism, the hyperflexion injury, the one thing in cartilage where you may be concerned with that is either meniscus or maybe a chondral flap, but both of which I don't see. He doesn't have any chronic changes. He doesn't seem to have much of an effusion. So I would be very much along the lines of what Alan said. I would probably wait and see.
Would you inject him at all?
I would. A little bit debatable in a 35-year-old. That's obviously been there longer than a month, what we're seeing on the MRI. So again, I would treat him symptomatically like they're talking about. I don't personally have a problem with an injection in a 35-year-old. That would probably be what I would offer him.
Okay, and not to get off too much on a tangent, but would you guys have any concerns with injections in general, or what's your constitution of what you put in an injection?
I tend to use cortisone an awful lot. I think as a first line single shot. It's for us, certainly it's free of charge, so there's no issues from an insurance point of view or government coverage. So I think it's a very easy thing to do. It's also, for me, it's very nice from a diagnostic point of view. If the pain, sometimes these patients present with fairly nebulous pain. You don't know exactly whether it's intra-articular or extra-articular, so I'm often using cortisone along with the local anesthetic as a diagnostic injection, hoping for some therapeutic effect from an anti-inflammatory point of view to allow them to get back into the rehab. And rehab's going to be the mainstay of this guy's treatment at this early stage.
Would you put any local anesthetic in your injection?
Yeah.
What do you use?
I actually use lidocaine, but it's a very small dose.
So you kill your chondrocytes really slowly. So there's obviously a lot of discussion about that. I mean, cortisone as a single-time injection, even in a perfectly normal articular cartilage, is okay. There's absolutely no data out there that suggests that would be otherwise. Now, if you do that chronically, it's a different story, and you should probably be careful combining it with local anesthetic. There is some work done by Jason Dragoo that suggests that lidocaine is particularly not a great combination. Maybe you should do marcaine, but this is also a dosage issue. Most of these studies are really done in cell cultures, which really don't replicate what happens in vivo. I have no problem doing these injections. However, I would probably not do this unless this patient has an effusion. If there's no effusion, I'm not even convinced at this point this is truly an intra-articular issue.
So those are good thoughts. The only thing I'd add in there is that there are some concerns for the chondrotoxicity. As Christian mentioned, a lot of it's in vitro data, so it's hard to know the clinical translation. There's been no clinical data to say that they're negative in this setting. And I do a fair amount of HA injections first to also see if you can kind of smooth things out. There's no significant evidence behind doing that either, but at least I feel like we're starting something non-operative for these patients, and also diagnostically I think it can be important.
Adam, regarding HA, so I work in an environment where we don't have any people who pay privately for this. So how do you get that through the insurance?
Yeah, it's a great question. So I've looked back at it, and we've had about 95% approval. And it's really because of the way it's described in the clinic note. So we call this focal arthritis versus a focal articular cartilage defect. And it seems like that is beneficial. I can't say for sure that's the tipping point, but it's something that we consciously try to do in young patients that have this problem.
Have you ever had any pushback later on? Let's say, God forbid, this actually turns into a cartilage lesion and you are trying to do a cartilage repair?
Yeah, no, it's a great question. That is my concern. So what Christian's bringing up is that if you kind of play that game and you make it seem like a small amount of arthritis, and now you're trying to do a cartilage transplant, and now you're getting approval for doing a cartilage transplant in a patient with arthritis, that can obviously be a concern. I have not run into that, luckily.
I have seen that a little bit because it is based on the ICD-9 or 10 coding, so you have to put an osteoarthritic code in to get HA approved, and then going forward with some of the OA grafts or ACI or MACI specifically, there's been some pushback that requires a little bit more peer-to-peer work. Adam, I'll throw one question out to you, a little bit being at Rush. PRP is something that people are talking about occasionally in this type of situation. Maybe you could comment a little bit on that.
Yeah, so I have a lot of patients that come in asking about biologic injections in general, so whether it's outpatient BMAC, PRP, an amniotic product, and I still describe it all very similarly, that we're not putting in there primarily to regenerate tissue. It's only to really calm down the overall synovial environment and try to calm down the synovial lining, which can be one of the issues with these patients because it's really treating this as a joint. That being said, it's never my first line of treatment unless a patient is really adamant against the other injections we've talked about. So that's about the most discussion we can have about an almost normal MRI, I think. So this is what their arthroscopy looked like. So clearly not normal, not the worst defect ever. It's a little bit, it's pretty close to what Christian was alluding to. So some flaps are involved there, probably grade 2 to grade 3, certainly no grade 4 changes throughout, and the meniscus probed to be stable. Oh, that was supposed to stop. Well, pretend like you didn't see that. You saw part of what might happen. What did you guys think about that?
So I clearly do a mechanical debridement with a very aggressive shaver, but no. Again, you know, it's, for me, still these 1 month history, you know, I, with no subconjugal bone changes on an AMR, I'd be still very, very much pushing the idea of rehabilitation. So for me, it's going to be injection, rehab, see him again in 3 months and see if it settles down. If it doesn't settle down, he's still symptomatic, then I think an arthroscopy is an option. I'm very, very non-aggressive with articular cartilage debridement. I tend to use a punch. I don't like to use mechanical devices. Certainly don't use ablation or co-ablation, but I'm sure that would be another discussion that we could have. But you know, I think it's not unreasonable as to what you said in your talk, is to just get rid of some of those little high nail type flaps of articular cartilage, at least to smooth that surface, and otherwise I'll be looking for other pathology.
So just to clarify too, thanks for bringing that up. This patient did have 2 sets of injections and physical therapy and was several months beyond the initial visit.
I think one good lesson to learn out of this is basically that the MRI, even with well-done MRI studies and 3T magnets and everything, we are still sometimes missing lesions, and we are still misinterpreting lesions. On that MRI, you know, unless there were other cuts that you didn't show us,
those are the best
that were
ones.
more clear in this, you know, that didn't really suggest that there was a mechanically unstable flap. And on the video, it sure looks like there's at least an element of that. And if the patient continues to be symptomatic, I think scope is fine. And this is a small lesion. This is a 3/4 thickness lesion with an unstable flap. I think debridement is the adequate thing here. I do the same that you do. I use, you know, a shaver to do that. On the edges, I may use a punch if it is a full thickness lesion. And then this is basically one of those cases that where doing less is better.
Yeah, so that's this case I kind of honestly hate, because you look at that MRI, there is something there, it is different. If you really scrutinize it, you can see it in retrospect. But these are the patients that you see that have a lot of pain, they don't have a lot on their MRI, and you don't want to say, well, like, we can do a scope and see if there's something in there. It's a 50-50 shot, and the more of these you see, the more you end up scoping normal MRIs. So it's a slippery slope. But Jeff, would you do anything different than debridement?
No, but these are the ones that I sometimes have trouble with on the arthroscopic treatment of it, because it tends to go further than you think it's going to go. When you start seeing those small unstable flaps and you say, okay, I'm going to remove that small unstable flap, all of a sudden now you get to a new area that becomes unstable. And I think the question that I often run into is, when do you stop? Saying that you maybe symptomatic, maybe it's the small flaps, maybe it's the cartilage defect that's causing it, but I don't want to create a much larger lesion at this point on the initial treatment. So I don't know. I don't know that there's one right answer to that, but oftentimes I will leave a small unstable flap of cartilage just because it continues to go back so far. So it is difficult.
One little trick here is, so you're obviously taking it down here, but one other trick that you can do is
this is not mine, but I'll tell you more about it.
If you have a lesion in that location, if you bend the knee to 90 degrees, you can actually bring your shaver perpendicular to the lesion, and then use it almost like a pencil to go around the edges, and that gives you a relatively nice stable rim. You can, of course, debride it that way too. If I would have done that here, I'm not sure, because I didn't think it was going to be that deep.
One point is that we haven't really discussed is alignment, and I'm probably going to sound like a bit of a broken record, but certainly in our scenario, I'll be looking at alignment with this guy because I'm still not sure exactly why he's getting that pain. And for me, if he's invarus, then we're looking at a much more sort of a medial overload sort of issue, which would be more alignment associated rather than just as articular cartilage. So that would be a key part of my treatment algorithm to see whether or not I could do an osteotomy, even in a 35-year-old.
Yeah, so I was going to try to move forward before you guys are like dropping your jaws at what's happening here. This is not my case. So this patient went through this treatment. So they ended up having what I would call well-performed microfractures. So that's using an awl, good spacing of the holes, no interface between the two adjacent holes, good stable border. So I think that was relatively well done, but again, a relatively small defect, and we got to figure out what's really causing their pain. We have patients with bone-on-bone arthritis with no pain, and so you got this little thing causing a lot of pain, so it's hard to know. So certainly, I would have been close to the end of stopping with the debridement. If you were to do a microfracture, can you guys just go down the line and say how you prepare it, what you use to try to remove calcified cartilage layer, and how you make your holes?
Pretty much similar. Demarcate the lesion with sharp dissection. So if I can use an 11 blade, I do, and take off the articular cartilage and the perilesional tissue with a ring curette, sharp ring curette, get down to the calcified layer and through it, and then exactly as shown in the video.
Same thing, I lose a sharp ring curette. In terms of the awls, I have started to use the ankle microfracture awls, which are smaller and much thinner, and therefore do not seem to violate the subchondral bone quite as much as the traditional ones, particularly if you have an old set that's been going around for the last 2 decades. You may want to reconsider getting a sharper, thinner one.
Yeah, I'm a believer in the subchondral bone as a pain generator, so some of these microfracturals are a little bit bigger, concern me with regards to the propagation of subchondral fracturing. So I will use a smaller, deeper wire, or occasionally even drill it with a K-wire if I can get a good angle on it with the knee inflection as opposed to using the awls.
Yeah, one additional point with what Christian's saying, there's actually really good awls in the foot and ankle arthroscopy set too, or I'm sorry, not awls, curettes. And so they have better angles, and they're usually sharper because they're being used less often. So I found that to be helpful. There's a question.
Adam. Not sure if this is, yeah. So Adam, there's some reasonable data if we go back historically about the use of coblation in this type of situation, not necessarily thermal, but just a stabilization of the articular cartilage. And this is one obviously where, it's not a 2-bone lesion where you may think about using that. Is anyone on the panel using that technology, and is there a role for it at all?
So I've been playing around with that a little bit. The new coblation technology is really not a temperature. You're not burning the cartilage any longer. This is really more a plasma flow that you're creating that is actually really low temperature. And the principle of it works. The problem is I think there's still some technological issues with it. It's actually really difficult to do because you have to have the angle absolutely perfectly in order to get that flow going. So I don't think in my hands this is ready for prime time, but I think it's certainly something that I think we have to start watching again as it becomes more available. As a technology, it's really not anymore what it used to be 10 years ago, where you're basically cooking cartilage.
think it's a great point, Nick. I think the literature that you may be alluding to is a study by Gunther Spahn that looked as a randomized study of coblation versus mechanical debridement, showed that the coblation had better outcomes 1-2 years. The problem there for me in that study is that there was no adequate control arm. There was no arm where they basically did nothing and left the articular cartilage alone. More recent study in JBJS has looked at debridement with just with a punch left alone, or with mechanical debridement with a shaver. Again, leaving it alone was actually, you had better outcomes. So I think until we see a study where they actually have an adequate control, can we really make a firm conclusion as to whether or not this is a good idea. Logically, it seems like a nice step. You smooth off the articular surface and you're going to get this pretty picture, and hopefully we'll improve our outcomes. I just don't think the data supports it at the moment.
Okay. So, and as far as the protocol, do any of you ever use microfracture and not follow a cartilage restoration protocol, so to speak, or to not use CPM, allow them to weight bear? Do you ever just throw it in as something to have and it's better than nothing and they don't want to do the rehab protocol, or you didn't talk to the patient about it necessarily ahead of time and they're not going to want to be non-weight bearing? How do you deal with those situations, or you always just be strict about it?
Very quickly, I never do a surprise microfracture, so they got to know about it ahead of time, and they got to be buying into the protocol that I'm going to use.
Yeah, I think the worst thing you can do is not talk to the patient about it beforehand, and then have them come out basically with a CPM and with crutches for 6 weeks, etc. You've just created a really angry patient. So no, they have to buy into the protocol, and I carefully select whether I do believe or not believe that they can actually do that. My suspicion is that they are typically much less compliant than you want, but for that reason you have to, I think, be very strict up front to at least get some of the effect that you're desiring.
Yeah, personally, I don't do a lot of microfracture just because I think there's concerns with the long-term data, but I would say that I treat this like any other cartilage procedure. I think if you get into, I'm going to do microfracture, and I actually see a fair number of people that were microfractured by other people just because they had an incidental defect, didn't do any sort of post-operative rehab, and they created pain where there wasn't pain before, because microfracture is certainly not a benign procedure. But if I'm going to do microfracture, it's going to be just like any other cartilage procedure. We're going to know we're doing something going in. We're going to treat it as such afterwards.
Yeah, so I kind of assumed I would get those answers from you guys, but I just really wanted to reiterate that point that you could see how in this setting you had a relatively normal MRI. You may not have thought you were going to see much of a cartilage defect. You get in there, you start doing this. Next thing you know, you're telling the patient there was one, you're non-weight bearing. It's really not a great situation, so just really try to plan ahead for that as much as possible. This is this patient's MRI 3 years later when he had worse pain than he had prior to his original presentation. And so you can see that subchondral edema, there's overgrowth of the defect there. And so it's still small, but it's a different animal than it was originally. And we have some stuff coming up on that next, so I'm not going to go into it. But I would just make an assumption so we can get to another case that bone marrow lesion would also be a negative prognostic indicator for using microfracture, would be my assumption across the panel, unless anybody feels differently. So this is a physician. His initials are MD also, so that's just a happy circumstance. But he has, these are his x-rays. He did have a prior medial meniscus bucket handle tear that was removed almost 10 years ago. He had no issues at all until just prior to presentation. He had an acute ACL rupture, and that was really what he was presenting for. You can see his overall alignment here is relatively neutral, maybe just mild varus. And this is what his MRI looks like. So what do you tell this patient? What's your plan leading up to surgery? And what are you going to tell him you're going to do with that defect?
So what are his main complaints? Is this guy complaining of instability or pain, or a mixture of both? Yeah,
it's a great question. He just came in with a big effusion. So he just came in with his initial presentation, knocked off that piece of cartilage is loose in the knee, and he ruptured his ACL. So you're seeing somebody after an acute traumatic injury, and they have this MRI.
Okay, so, I mean, essentially, for me, so now we're looking at two different issues. We're looking at an articular cartilage lesion, but also we're looking at an ACL problem. So if I'm thinking about doing anything to his articular surface, I want to be doing that in a stable knee. I want to do it in a quiet knee. He's got an effusion. I want to know what his range of motion is, so I want to try and get him rehabbed appropriately prior to surgery, and then I'm going to be having a discussion with him about doing ACL reconstruction, and then trying to establish whether or not adding in some form of cartilage procedure at the same time is appropriate. Now, if he's got an effusion, is that a hemarthrosis versus actually a reactive effusion from the articular surface? My guess is probably it's more of a hemarthrosis.
Yeah, hemarthrosis.
So for me, and certainly in my practice where I don't necessarily have really great access to a lot of cartilage repair solutions and they're very expensive, so I've got to really hold off a little bit. I'm much more on the line of treating his ACL, getting him a stable knee, rehab him, and then see what his symptoms are like later. And again, if you look at the data from the ACL literature, if you leave some of these lesions alone, the outcomes are better. If you treat them, certainly if you treat them with a microfracture, the outcomes compared to just leaving them alone actually is detrimental. So, but you know, he's got poor prognostic indicator as his subchondral lesion. So, Christian.
Yeah, so if he had absolutely no symptoms with his knee prior to that ACL injury, then I would probably try to do this also in a more staged approach and basically stabilize him first and see what happens. But you do have to talk to him about the fact that this medial edema that he has here is not a consequence of the ACL tear. That is likely a consequence of that lesion, so he may have already been working on something there, and I think you need to tell him that. Particularly the guy is a physician, so he needs to plan stuff ahead. After an ACL, you can walk pretty quickly. He can probably get back to work pretty quickly. If you do a cartilage procedure on him, or God forbid, a meniscus and a cartilage and an ACL, he is out for a long, long time. So I would stage this.
Yeah, I agree with everything that's been said thus far with a slight modification in that he would have to prove what his symptoms are leading me to do. So if it's instability, obviously you do an ACL. If he's got pain, effusion in that location, then I'm considering a cartilage procedure. I think the difference is that I would not necessarily do the ACL first. I would go through a period of non-operative treatment, maybe 3 to 4 months or so, because I think people can be fairly functional with an ACL tear, and especially given a professional or a physician who may not like the idea of 2 surgeries, I would try and delineate what his clinical symptoms are before I did anything. So 3 months, good motion, doing straight line running, not having a lot of pain, but instability events with turning corners, I would do an ACL, then I would just let the cartilage be. It's probably been like that for a long time. 3 months of maybe inline running, starting to have medial pain, starting to have effusions, having more problems than instability, I would then consider doing an ACL and a cartilage procedure at that point.
Alan, you had a question or thought?
Just looking at his MR as well, his medial meniscus is in poor shape too. You alluded to his alignment. My guess is that his mechanical axis is probably just sitting on his tibial spine.
Yeah, just medial.
This is a real problem for this guy's knee, and certainly the ACL is not going to change his natural history of his knee. This is now on the downslope. So in terms of what you asked, in terms of counseling the patient, the ACL is going to give him a stable knee, but in terms of long-term health, osteoarthritis, he's got significant issues, and the only thing that's really likely to really change that is changing his alignment somewhat. And if I can't do an osteotomy, that's a bad problem to have.
Yeah, and so you guys are hitting on everything that I want to make sure we're covering. Jeff, I probably did something the most similar to what you're describing. This is a very active, fit physician also. He's about 35 years old. I don't think I mentioned that. And so everything that you guys are all mentioning is obviously relevant. His prior meniscectomy and doing an ACL in that setting is obviously a concern, as well as the potential for pain in this area and the chronicity of it that was likely more than what it appeared with the ACL injury, like Christian mentioned. So I did have him do a significant non-operative period to have him run on it and do exactly what you mentioned, Jeff. And he had some baseline small aching there in that area, but it's something that he said if that's what he was dealing with, he could live with it. And so we did do isolated ACL reconstruction. Here was the large piece that he did knock off and delaminated at that time, but it doesn't mean that that's when the problem started necessarily. And then this is what his lesion looked like. So these are always bigger than they seem on the MRI, and you can be really tempted to do more for this because you're in there and you could just do a microfracture, but he's about almost 2 years out now and back to running and has no pain in that compartment. His ACL has stayed stable, so we haven't done a meniscus transplant, OA graft, HTO, nothing like that. So really try to take the time to tease these things out and make sure we're not over-treating patients, which is really what you heard from everybody on the panel. And this patient really has no meniscus there whatsoever. So just think about that also. If you're going to do something like a microfracture in the setting of a meniscectomized compartment, it's really, really hard to justify that. Here's another case. So this patient had a prior meniscectomy. We'll go through this one a little bit quicker because I want to get to one after it. So this was the same idea, bucket handle medial meniscus. When she was younger, it was removed. She's mid-30s. She now has developed pain in the medial compartment. And I'll kind of move through this one, but essentially this is what her video looked like. So she did have a flap tear of the meniscus. Then also when we look at the actual cartilage itself, there was this creeping substitution from the edges there. But I'm sorry, that was a video, I'm sorry about that. But those are flaps that could be easily lifted up and they were easily mobile. And so this patient just had a debridement of her meniscus. She still had a prior meniscectomy in the past, so she doesn't have a functioning meniscus and a debridement of this lesion. And she did extremely well after this symptomatically. So again, sometimes less is more. And this is the last one I want to talk about. So this is a 38-year-old, so she's almost getting to 40 years old. She has pain that is associated with swelling. She's had multiple injections as well as physical therapy, and her pain is retropatellar, and it's also medial joint line and lateral joint line. Most of her pain, and probably 60%, is medial joint line, and then probably another 30% is patellofemoral, and then a minority is lateral condyle. And so, do you guys see anything of significance on those MRIs? The X-ray is pretty normal.
I don't see anything of real significance. I mean, these are my, what age did you say she was?
38.
So these are my nightmare patients, really, in that, you know, it's the deconditioned female with anterior knee pain. And, you know, this is, for me, this is rehab, and more rehab, injections, more rehab. But particularly in view of the fact with very little bone marrow signal, subcondylar, there's no subcondylar issues. I mean, there's some swelling, there's some edema in the articular surface and the lateral facet there, but on the axial view of the retropatellar surface. But I don't see anything that I would be happy treating operatively. So certainly this is definitely non-operative treatment in my book.
So definitively forever. No surgery ever offered. I mean, I'm saying she's been through all the stuff you were mentioning. That's why I say that.
I mean, I think one thing that you can do, which we often use, is actually get them to demonstrate how weak they are in clinic. So I get them to do some squats, single leg squats, and really demonstrate how weak their glutes are, their core, and that actually brings it home to them that, yeah, they may have been in physiotherapy for 6 months, but they actually haven't been doing their rehabilitation appropriately. So I think you just got to really push for rehab.
So looking, I mean, this is a patient that we all see, and that is exactly what Alan says. This is a nightmare patient because we are not dealing here with just one problem. You know, she has some beginning changes in the trochlea, so if you go in there and scope that, this is probably the person where you see pretty much grade 2 changes all along in the trochlea, along the medial condyle. She has a couple of smaller lesions there. Doesn't seem to have too much in her fusion. There may be some synovitis in the hoffa. In the front, deconditioned knee, probably a little bit overweight. That would be the typical patient who I would see with that. This is a patient that you try to work on non-operatively as long as you possibly can, and try to modify activities, optimize weight, may work with injections, until I see any significant different situation here.
Yeah, I agree with everything they've said. I think the one difference is the little U.S. versus Canadian perspective on this. This is certainly a patient that starts with an arthroscopy first, and use that arthroscopy as an excuse to really focus on a post-operative rehabilitation protocol. And these are patients that occasionally do better and never make it to that second stage of the cartilage procedure.
Yeah, so it's a difficult patient, and she had extensive non-operative management, continued to have pain, lots of discussions about whether or not she would even go through with a second stage procedure, and we did get to the point of doing this arthroscopy, so just take a look at this and see if you have any different thoughts of what you would do with her at this visit. So there were some flaps there that I debrided that were loose, particularly on that second defect there. Grade 4, relatively focal, not a lot of continuity between defects here. So there's another one on the medial femoral condyle, grade 4. So, and this is really tricompartmental. They're not large, but they are there, and she does have pain in those areas. So I'll just tell you that after this arthroscopy, she conceded that the lateral pain was not that significant. Most of her pain, retropatellar, got better too after that debridement. And now she's left with dull, aching medial pain in her medial condyle. And so if she's saying she's still not happy and most of her pain is medial, would you offer her anything else? What would you do next for her?
Yeah, I would be careful to try to go in there and do anything major because, I mean, this is a case at that age with these type of lesions, the way they are distributed, this is bad genes, right? Yeah. I mean, this is a chondropenic patient that basically starts flaking off cartilage in various different areas. I do not, of course you can go after each one of them and fill them with little plugs and with allografts or with cells or whatever you want to do. This is a patient that then comes back 4 years later with a beautiful plug in there and everything else around it is broken down. So I think you need to tell them that, and again, I would be very, very cautious to jump in too far here.
Yeah, I buy what you're selling, Adam. I like this case. It's a difficult decision-making process because I think first, like you said, you have to delineate symptomatically what lesion you think is the problem there. But if they've really failed all of their conservative management, that cartilage, I agree with Christian, this is a genetic issue, but it looks relatively well maintained thus far. To me, this is a surface treatment at most of 2 lesions. I think getting into the tri-compartmental treatment, I think is just, it's not going to work real well.
Yeah, so those are all the points I was hoping we'd be able to cover. So this is really scoping an arthritic knee before they develop significant arthritis. And so it's just hard to know what to do with this patient. And it's a lot of counseling with the patient, really understanding their expectations, the duration or the durability of what you're about to put in there. And for me, that's another reason why I like to do these as a 2-stage procedure. So Jeff, would you ever do a surface-only treatment at the time of the initial scope, or would you wait and stage that?
Never, always stage.
Okay. Okay.